in India, and then good morning, everybody on the US side. Welcome again. We are very excited that we have excellent panelists today. We have two great speakers, and we have Dr. Patnaik as our moderator today. So Group Captain Dr. Saroj Kumar Patnaik, he is an MD Pediatrics from AFMC, and he is a DNB Pediatrics, and he has completed IPNA Fellowship in Peds Nephrology from All India Institute of Medical Sciences. He is currently the head of the department and professor and senior advisor for pediatrics and pediatric nephrology at the Command Hospital, Air Force, Bangalore. He has immense amount of experience in pediatric nephrology across various armed force hospitals. He established the Peds Nephrology Service in Command Hospital in Kolkata, in Bangalore, and Army Hospital Research and Referral Center. His key interests are biomarkers in acute kidney injury, neonatal nephrology, cardiovascular outcome renal disease, and nephrogenetics. He has been the past secretary of Indian Society of Pediatric Nephrology, and he has been also the member of Subspecialty Board for Pediatric Nephrology for NBEMS since 2020. He has received numerous awards, which include the award for the best research abstracts in IPNA in 2010, and he has also received the Best Reviewer Award of the Medical Journal of Armed Forces India in 2011. We are really excited to have Dr. Patnaik here, and I will hand you the session to you, Dr. Patnaik.
Thank you, Dr. Jain. At the outset, I would like to thank Dr. Kalaivani and you for the invite. And without wasting any further time, I would now like to welcome Dr. Suresh for starting the first session. Congenital anomalies of the kidney and urinary tract are a wide-ranging spectrum of anomalies, and while a large number of them are detected in the antenatal or immediate postnatal period, a significant proportion, especially in settings like India, where the antenatal imaging services may not always be available in terms of the quality, and a significant proportion still remain to be identified in the adult population with varying degrees of severity. Now, Dr. Sudarshan Suresh is an MBBS and a DNB in Obs and Gynae with a fellowship in fetal medicine. And he has the Dr. Suresh Mediscan Systems Private Limited and is a consulting fetal medicine specialist in this entity and practices from Chennai, Tamil Nadu. Dr. Suresh, please, too.
Thank you, sir, for the kind words. And I thank Dr. Kalaivani and the team to have me as part of this session. And I will be dealing with the prenatal presentation of congenital anomalies of the kidney and the urinary tract. Let me just share my screen. Slideshow. Is this in full screen mode, sir?
Yes, it looks, in two screens right now, and you could start from the first slide, please.
Now this is in single slide mode, sir?
Yeah, it's looks perfect, Dr. Sudarshan. Thank you so much.
Well, good evening. And so this session is going to be on the prenatal presentation of congenital anomalies of the kidney and the urinary tract. So any problem involving the urinary tract has got its origin predominantly in the early period of the pregnancy. That's a developmental period that starts from the conception time to the first 9 to 10th week. And at these points of time, when you have insults which happen in the embryonic development, you have the varying spectrum of the defects, which involve either the kidney, ureter, the bladder, or urethra, and you have the spectrum of problems that we tend to see, which range from the worst spectrum, which is the renal agencies, to the slightly different presentations involving renal position malformations and obstructive malformations. So let me begin this session by taking you through the methodology by which we do the antenatal assessment of the fetal renal system. We start by assessment of the LICR, which is the index of the renal function. We assess the fetal urinary bladder. Then we do a systematic fetal nephrosonogram, and that will complete the routine assessment. The first step is to assess the LICR. The moment we start doing the antenatal scan, we evaluate the LICR volume. And the fetal kidneys are the major contributor to the LICR volume after 16 weeks. Till that point of time, the LICR around the baby is contributed predominantly by the placenta, the skin, and the fetal umbilical cord. But beyond that point of time, it's the renal system. So when we have a baby that does not have any LICR beyond the 16th week, then we think of potential problems involving the renal system. And the methodology of assessment of the LICR volume in the part of this in the pregnancy has got a very stepwise protocol. Up to around 28 weeks, we measure what we call as the deepest vertical pool. Beyond that point of time, we measure the amniotic fluid index, which is the 4 quadrants. At any point of time, when this LICR volume is less than 2 or the amniotic fluid index is less than 5, we consider that the baby has got severe reduction in the LICR, and that may be due to various causes which are impacting the renal function in utero. The next step is the assessment of the urinary bladder. The production of the fetal urine starts by around 10 weeks in most, and the urinary bladder can be visualized by 11 weeks in over 99% of the cases by a combination of transvaginal scan and a transabdominal scan. This is a transvaginal picture of the cross-section of the baby or the pelvis. You can see the urinary bladder that's flanked by the umbilical arteries, and the filling and emptying of the bladder is seen every 25 to 30 minutes, and the filling time increases as the gestational age increases. You can see the urinary bladder here. This is a transverse plane, and this is the coronal plane of the fetal abdomen where we check the bladder. As you can see, this is the urinary bladder from 12 weeks, this is at 20 weeks, and this is at 34 weeks. So because the ability of the bladder to expand and then retain the urine for a longer time is there, you have the bladder which distends to a much bigger extent as the pregnancy progresses. At the early part of gestation, we see a very tiny bladder, hardly of a size less than 5 to 6 mm, and that keeps filling and emptying very, very fast. When we assess the bladder more objectively in the mid-trimester scan, we try to see the thickness of the bladder wall at the level of the umbilical arteries. Do we do that routinely? We don't do that routinely. We do that if we find some abnormality in the appearance of the bladder or the renal system. Next, we go and see imaging inside the bladder cavity. Sometimes we see these cystic areas inside the bladder cavity, and these are suggestive of a dilated ureter, that is the urethrocoel. And we also assess the posterior urethra and the external genitalia as part of completion of the genitourinary tract system. The posterior urethra is usually never dilated in utero. When it's dilated in utero, then it's a pointer or an obstructive urethra. The technique for imaging the kidneys has been laid down by the International Society of Ultrasound OBGYN, and that process takes you through a longitudinal scan across the baby. So you have the spine of the baby here, which is anterior, and whenever the spine is anterior, we'll be able to assess the kidney because the kidneys are retroperitoneal organs. So the moment the spine is an anterior structure, we'll be able to image the kidneys very well. So we always image the kidneys in two different planes. You can see the anterior spine. This is the kidney seen in the sagittal plane. You can see the renal capsule, and the small black area inside here is the fluid in the renal pelvis. And this is a kidney in the transverse plane again, and you can see both the kidneys on either side when you see it in the sagittal and the transverse plane. The length of the kidney, which is measured when you see the edges of the capsule very well, is by a rule of thumb equal to the gestation age in weeks. For instance, when you see a baby at 24 weeks, the renal size will be around 25 mm. Then we always assess the kidneys in multiple planes. The rule in ultrasound is when you see an organ in one plane, you got to reassess the organ in other planes because we can avoid pitfalls of it. The kidney as an organ to assess in the mid-term is very, very challenging because the echogenicity is very similar to the bowel that is nearby. This is the kidney and this is the bowel, and they eerily look very similar. And a differentiating factor here is only a small amount of fluid inside the kidneys and the presence of this hypoechoic or the black colored adrenal gland that is seen on top of the kidney. Or else you will see the kidneys merged with the bowel, which in fact is the reason why a large number of times we have pitfalls where the bowel is thought of as a kidney and these diagnoses are missed in the mid-term scan. So this is a normal appearance of the kidney in the first trimester. So when we image a baby between the 11 to 14 week period, we call it as the first trimester period. And at that point of time, when we do a transvaginal scan, we will be able to see the kidneys. Very similar echogenic structure with a cystic area inside, cystic area of the renal pelvis. And this imaging of the kidneys is feasible in a 12-week scan in almost all patients once the baby's size or the length is more than 6 centimeters and we do a transvaginal ultrasound. Then we assess the location of the kidneys. So the kidneys usually develop in the pelvis at the level of the sacrum, and by 9 weeks the kidneys ascend and move up to the renal fossa. And the kidneys must be seen on either side of the spine in the renal fossa when you image the baby in the coronal plane. But sometimes when these kidneys do not move up to its position, you see a kidney in the wrong position. For example, there's a kidney which is not ascended up, it's in very close to the urinary bladder. At this point of time, this is a baby having a pelvic kidney. One additional imaging parameter that we use to reduce the pitfalls in renal imaging is the utility of the renal arteries. So if you have the kidneys on either side in its position exactly, you will have these renal arteries which are given forth from the abdominal aorta, which go perpendicular to the abdominal aorta. This is a baby having a renal artery on one side, there is no renal artery on this side. This corroborates our finding when we suspect an absent kidney on one side. Very similarly, when you have a kidney that is there in the pelvis, you will have an aberrant vessel from the lower end near the iliac vessel, which is draining the kidney at this point of time. So the utility of the renal artery and scan helps you reduce the pitfalls in renal imaging. As I said, the size of the kidney is measured in the sagittal plane, and there are normograms. The rule of thumb is equal to the gestation, and sometimes locating the upper pole and the lower pole may be impeded when we have shadowing from the ribs here, and that may impact it. So we have to rock the probe up and down to assess the kidneys, the location properly. Then we move on to assess the renal parenchyma. When we want to assess the renal parenchyma, we see that the kidneys parenchyma appears hyperechoic in the first time, which is little bright, and the corticomedullary differentiation starts by around 14 to 15 weeks, and it's seen very well by around 18 weeks, wherein the cortex is hyperechoic and the medulla is hypoechoic, black and white. This is histopathology is a gross section, a cut section of an autopsy of a baby's kidney. You can see these lobulations that are here. These are the fetal lobulations that are normally seen near the cortex and the medulla that is seen here. So when you want to assess the renal parenchyma, an extended renal sonogram, we assess the echogenicity, how bright is it? We assess the corticomedullary differentiation. You can see some areas are bright, some areas are black here, and these black and these white areas represent the medullary pyramids that are there, that differentiate the cortex and the collecting system. Then we look for the presence of any cysts inside the parenchyma of the kidney, and we look for any dilatation of the kidney system. And when we do this imaging, we have to give a lot of focus on the resolution of the transducer. Sometimes when we use a very high frequency probe, everything will appear bright, and we may end up making a false diagnosis of a hyperechoic kidney that will take us on a tangent. So we measure the renal pelvis. Renal pelvis is always measured in the anteroposterior diameter, never in the coronal plane. And in up to 28 weeks, less than 7 mm is considered normal. Between 28 to 40 weeks, less than 10 mm is considered normal. So these are the appearance of the kidneys from the mid-trimester scan to the third trimester scan. What is the difference between this image and this image? We can see things much better here compared to here. This is a trans-abdominal scan. This is a trans-vaginal scan. So whenever we suspect some pathology in the kidney, we wait for the baby to come to a breech plane so that we'll be able to do a trans-vaginal scan to assess the renal parenchyma much better. This is a baby in the third trimester, almost like a newborn. So you have a very well differentiated corticomedullary differentiation. And unless this picture is there in the mind, this again is sometimes noted as pitfall. People tend to think that these are cysts in the kidney and make false diagnosis of a polycystic kidney. Then we have the last structure, the ureter, and the ureter is the most innocuous structure because we never see it in the transferring on the imaging unless and until it's dilated. The rule of thumb in prenatal imaging is if we see the ureter, it means it's dilated. So with this background, we go on to assess the abnormalities. The abnormalities can be in kidney number, where we see a renal agenesis, unilateral or bilateral. Then we look for abnormalities in the kidney size, hypodysplasia of the kidney, or morphology, which is a cystic dysplasia of the kidney. Then we look at position abnormalities, which can be a low-placed kidney, or a pelvic kidney, or a horseshoe kidney, or ectopic kidneys, which can be in different patients. Then we look at outflow abnormalities in the kidney. It can be at the upper tract, a pelviureteric obstruction. It can be at the lower tract, a ureterocele. Can be a megaureter. Can be due to refluxing system. Can be due to urethral valve or a urethral. Let's start with the first problem, which is a bilateral renal agenesis. The suspicion on ultrasound happens when we don't see any biker, and then we do an imaging, we do not see the kidneys, we add the renal artery imaging, we don't see any arteries. So this combination of an absent bladder and hydramnios, an absence of the renal arteries, helps us make a diagnosis of bilateral renal agenesis. Sometimes the kidneys can be so dysplastic that they are not imaged at all. Hence, prenatally, the reporting methodology is to give a report of a bilateral empty renal fossa and rather than a bilateral renal agenesis. Many times, these problems are associated with other abnormalities. And when we do imaging in the mid-range scan, because of the absence of Leica, we would not be able to assess the rest of the conditions. So a complete assessment as to whether this is an isolated problem or whether it's a part of a multi-system anomaly can only be done after termination of pregnancy. One common problem that comes along with this is a condition called cyanomelia, where there is a regression of the lower part of the body, and these babies will never be able to make it out, especially when the Leica is anhydramnios in the mid-trimester. Then we move on to abnormalities involving one kidney. Abnormalities involving one kidney can be suspected sometimes as early as the first trimester scan, but usually it's a diagnosis at the second trimester, wherein around 19 to 20 days. Again, suspicion is absence of the kidney in the renal fossa, and at this point of time, we do not see the adrenal gland. The adrenal gland appears as a black structure here. Here we don't see the chunky adrenal. The adrenal gland lies down. We call it a lying down adrenal sign. And we also corroborated with the absence of the renal artery on that side. And when we do not see the kidney in its position, we also use color Doppler to see the aortic bifurcation angle. The aortic bifurcation angle is very narrow. It tells us that the kidney is not there in the pelvis. So when we have a single functioning kidney, many times as the pregnancy goes, we see that there is a compensatory hypertrophy of the other kidney over 90% of the cases in utero. And when we see a unilateral renal agenesis, in around 30% of the cases, we see associated malformations. They can involve the spine, they can involve the bowel, they can involve the genitalia, they can also involve the cardiac system. Some of these abnormalities are not amenable to antenatal reduction. For example, those associated with anorectal abnormalities, especially in imperforate anus or a low anorectal malformations, or tracheostomy fistulas. Time and again, we have seen these babies when we have seen a unilateral renal agency on spot. We see this diagnosis in the postnatal period. Then we move on to position of fusion of these, and for that we have three signs. Again, an empty renal fossa on one side, an abnormal origin or course of the renal side, and a wide bifurcation. So in this group, again, a large number associated with other congenital complications. So detailed fecal echocardiogram and rest of the anatomical scans essential. So this is a normal bifurcation angle. It's less than 55 degrees. And when you have a baby that is having a kidney that's there in the pelvis, it's placed the iliac bifurcation angle. So this is a baby having a pelvic kidney. This is an autopsy picture done at a unit of the same baby. Pregnancy was terminated because this is part of a multi-system anomaly. You have the kidney that is there lying in the pelvis. So the iliac angle is very much wider. It's more than 55. It was a very old publication of unit where we actually had a kidney that was noted in the thorax, diagnosed concomitantly, and confirmed on the histopathology. Then you have the next common problem, which is the horseshoe kidney, where you have the fusion of the lower poles of the kidney and they are mal-rotated. Again, prenatal diagnosis of this problem is very challenging. Many a time it's diagnosed as a kidney that's not there in the renal fossa or a slightly small size kidney. The ability to pick it up again is dependent on drawing these angles, what we call the renal pelvis angle that I have drawn here, and an angle of less than 140 degrees has got a good sensitivity and specificity to identify this problem in the nutrient system. Then we come to problems involving the renal size and the morphology. Size can be hypoplastic kidneys, which are small size with normal architecture, or a dysplastic kidneys, small size but echogenic architecture or a presence of cysts. Our concerning thing is always the second part, which is dysplastic kidney. A dysplastic kidney is one where the parenchyma of the kidney is replaced by multiple small cysts studded along the periphery. And these cysts can be small like this, or they can enlarge and become big layers. And this is a baby having one kidney, left kidney normal, while the right kidney has become cystic dysplasia. And this is a baby having bilateral multicystic dysplastic kidney. And this presents with anhydramnios, this presents with a completely normal height. And it is in these cases where we need to figure out why this problem happened or the presence of associated problems. Next, we have a kidney that is echogenic or bright. A slightly bright kidney can be a completely normal area. It can be a pitfall when you use a high frequency probe. Very important to see the size. If the size of the kidney is normal or slightly small or it's very large, because it can be a part of also congenital nephrotic syndromes or hereditary cystic diseases or dominant or recessive polycystic kidney disease. Let's see how they perform. This is a tiny gravida referred for a routine target scan at 23 weeks. We saw that the kidney was huge, it's close to 5 centimeters, and it's very bright and echogenic, and the parenchyma is not looking normal, and the corticomedullary differentiation is completely lost. And this pregnancy, once this was seen, the first step that we do is to take a detailed family pedigree and counsel the parents on the need for a KUB scan of the parents. Assessment of the parents showed that the mother had enlarged kidneys with multiple cysts. His mother had a polycystic kidney, and the family were counseled that was due to a genetic disorder, and a prenatal sampling was taken. Pregnancy was terminated. This is the size of the kidneys on the autopsy study. This is an autosomal dominant polycystic disease. PKD1 gene is the association, and it's got a close to 50% recurrence. Then we have a pregnancy having kidneys which are echogenic and bright, and this presents that with mid-trimester complete anhydramnios, and this condition is usually bilateral. This can be associated with hepatic fibrosis, and this is again a genetic condition which has got a 25% recurrence in every pregnancy. In prenatal sampling by checking the fetal blood and sending appropriate genetic tests is essential to help guide the family towards subsequent pregnancy. This is a third variety of kidneys. We saw two echogenic kidneys which are huge in size. But this is a baby having a bright kidney. You can see it's bright white but very, very small. And this patient had a very significant history. First baby died at day 12 due to liver failure. Second baby had echogenic kidneys scan, neonatal device. This was the third pregnancy. And this was the picture in the third pregnancy scan. Very small echogenic bright kidneys there. And prenatal sampling was done. Pregnancy was terminated and autopsy was done. On autopsy study, this was the kidney appearance. And you can see that the diagnosis was not seen on the gross examination, but it was seen on the histopathological examination. On histopathological examination, we found diagnosis was one of congenital Finnish nephrotic syndrome. This is an autosomal recessive condition. This family genetics testing was done, and we were able to provide a solution for the subsequent pregnancy. Then we have a patient having mildly echogenic kidneys with completely normal lighter. This is an enigma because we don't know what the diagnosis is. Very likely it can be part of a normal variance also, but it can be part of a syndromic pathology. In this particular baby, this baby is well after death. So echogenic kidneys can be a very wide spectrum ranging from normal to genetic renal disorders. Then you have a pregnancy where the kidneys are not only bright, but the kidneys have multiple cysts, and these are not those large cysts that we saw. But this baby also had an occipital encapsulation, and an examination by transvaginal scan showed a polydactyly of the hands and feet. And this triad of a cystic kidney, encapsulation and polydactyly, is pathognomonic of Meckel-Gruber syndrome, a genetic disorder of or belonging to the celiopathy group. Presence usually at around 10 to 12 weeks and very high penetrance. So we can make the diagnosis early, but if the genetic cause is identified, then pre-implantation, the diagnosis can be made to offer them or to prevent recurrence in subsequent pregnancy. These are babies having cystic dysplasia. These are very similar to the prior picture, but I call them cystic renal disease because these kidneys were apparently normal in the initial scan. But as pregnancy progressed, due to an obstructive uropathy, progressively the kidneys have gone to dysplasia and there is no liquor, as you can see. And in these cases, you can note that the bladder is very geographic and odd because of the obstructive pathology that has happened over a period of time. These are again the gross sections. You can see the distended bladder and the dysplastic kidneys on the autopsy picture. So when we see an echogenic kidney on the scan, this is how we see. We look for the size, the liquor, corticomedullary differentiation. Normal size, normal CMD, normal liquor, possibly normal variant. If it's small in size, could be due to a cystic renal dysplasia or congenital nephrotic syndrome. If it's large in size, if there are no associated anomalies, it can be due to a dominant or a recessive polycystic kidney disease. If there are associated anomalies, it could be part of the syndromic etiology, as I showed here. Then we move on from the echogenic kidney spectrum to the obstructive uropathy spectrum. Obstructive uropathy spectrum are more common than the other things we saw in the prior scans. But what I'll do is I'll change the terminology from one of obstructive uropathy to a more uniform terminology that we use, which is the UTD or the urinary tract dilatation. So urinary tract dilatation occurs 1 to 5% of pregnancies, which is quite large, which means 1 in 100 patients you will see urinary tract dilatation. 80% of them are transient physiological. The rest, it can be due to an obstructive pathology. In some, the cause is usually not determined. And a simple dilatation is not obstruction because dilatation is a dynamic process that keeps changing as the pregnancy goes. So we standardize the terminology. We don't use all these now. Hydronephrosis, pilectasis, pelvictasis, uronephrosis, all of them has gone out of the window, replaced by UTD A1 or A2 So the criteria used are the anteroposterior diameter of the pelvis, the chalicial dilatation, presence or absence of parenchymal echogenicities or abnormalities, the bladder, the ureter, and the amniotic fluid volume, and the presence or absence of associated malformations. So the UTD classification divides them into pregnancies at 16 to 28 weeks and above 28 weeks. Between 16 to 28 weeks, less than 7 mm, is not 4 to 7 mm is considered as mild, or after 28 weeks, 7 to 10 mm is considered mild. These mild dilatations belong to the UTD A1 spectrum or the low risk spectrum. But before 28 weeks, when the pelvic dimension is more than 7 mm, or after 28 weeks, when the pelvic dimension is above 10 mm, or you see abnormal parenchyma, abnormal ureter, abnormal bladder, or an unexplained oligohydramnios, it goes to the high risk group or the A2 to 3. And why is understanding this essential? Because if it's in the A1 category, the postnatal pathology is hardly 10%. If it's in the moderate to severe category, postnatal problem is 45 to 90%. And this pelvic dilatation, UTD A1, would regress in over 90% by the third trimester of pregnancy. In some, it just remains static. In 10% of the cases, it can progress to UTD A2 to 3 in later scan. So the recommended methodology when we see UTD A1 low risk, prenatal period, one additional ultrasound at around 32 weeks, and postnatally ultrasound that is done after 48 hours and 6 months later. We also assess if there are other markers of chromosomal disorders. If they are not there, we reassure the patient. But when we see UTD A2, A3, prenatal period, we keep seeing 4 to 6 weeks because there can be a rapid change and the prognosis cannot be predicted. It depends upon the evolving nature, and the subsequent follow-up is purely based on what we see on the follow-up scan. The postnatal classification is a continuum of the prenatal classification. I won't go too much into this at this juncture, but the UTD A1, 2 to 3 correspond to the UTD P1, P2, and P3, which is a low, intermediate, and high risk. So when we go to the obstructive pathology, obstruction here, we call it a PUJ obstruction. It can be unilateral, bilateral. Obstruction here is a uretrovesical obstruction, uretrocele, and obstruction here can be due to a POD or a urethral issue. All these present prenatally, and one simple rule of thumb: earlier the presentation, worse is the prognosis because the renal function gets affected. This is case 1. This is a baby having This is a case 1 having a pregnancy at 24 weeks. One kidney is normal, other kidney has got a dilatation. You can note progressively from 24 to 30 weeks, the dilatation is increased, the initial dilatation is more, and it is this progressive dilatation involving the central and the peripheral perishes is very classical of a unilateral PUJ obstruction. 20 weeks, one kidney 8, other kidney 11. 8 and 11 belong to UTD A2 to 3. They were seen 4 weekly. Bladder was normal, which means there is no obstruction of the lower tract. At 26 weeks, increased to 13 and 25 mm. By 32 weeks, one side has increased to 36 mm, other side 15 mm. Bladder was normal. Renal cortex was thankfully normal. So a case of bilateral PUJ obstruction without any renal parenchymal damage. So we reported based on this. AP renal pelvis diameter, chelicate dilatation, parenchymal thickness, whether it's a thick or a thinner parenchyma, dilated ureter bladder, or presence of liquor, and we give the UTD A2 to 3 or A1 category, and we suggest a management plan. From the upper tract, we move to the lower tract. This is a patient having a kidney. Right kidney was normal. Left kidney, if you look at it, the lower pole of the kidney looking completely normal. Upper pole alone is dilated. Can this happen in utero period? This can happen when there is a double moiety and there is an obstruction of the ureter of one moiety. So this pregnancy, at the initial scan, only the upper moiety dilatation was seen in the pelvis. We couldn't see anything. She came back for a follow. On the follow-up scan, when the bladder distended, you could see the uretrocele document here. So there was a double moiety with a uretrocele of the upper tract ureter, and that was causing this progressive dilatation of the kidney in the upper pole. And this is not a diagnosis easy to make because the uretrocele collapses easily, and incidentally if it dilates, only then you'll be able to make this diagnosis. We move on to the lower urinary obstruction. Lower urinary obstruction, the incidence is 1 in 250 to 1 in 1000. and it can be due to any of these problems. And if it's urethral atresia presentation in first trimester, it's a posterior urethral valve anytime between the first to the third trimester. Let's start from the first trimester. A distended bladder. Anytime a urinary bladder is above 7 mm, we consider it as called megacystis. When it's above 15 mm, it's severe, very classical pointer for an obstructive uropathy. When it's up to 15 mm, we got to rule out aneuploidy. More than 15 mm, think of obstructive pathology. Always when we see this, we look at the kidneys, we rule out Down syndrome. This baby, chromosomal abnormality was there, baby had trisomy baby. And any baby having a bladder outlet obstruction diagnosed in the first trimester, very poor prognosis. By 16 to 20 weeks, we see anhydramnios or sometimes intrauterine device also. This is a baby in the first trimester having bladder outlet obstruction, megacystis, absence of the cranial wall. This is an autopsy picture. Baby had a acrania. This baby had a complete urethral atresia, resulting in bilateral hydronephrosis in the first trimester. When we move on to the second and third trimester, we have seen that the first trimester prognosis is very bad. In the second trimester, it can present very classically like this. We see a male baby, a distended bladder, dilated posterior urethra, classical three-hole sign with a bilateral hydronephrosis, and this is a triad picture of a posterior urethral valve. Sometimes what can happen if this progresses, it can result in progressive upward back pressure. So the pressure in the kidneys becomes more, and there is a rupture of the calyces. You end up seeing a perinephric urine or not. And sometimes if the bladder ruptures, you end up having a urinary ascites. And when you see a perinephric urine or a renal cyst or a urinary ascites, these are signs of progressive disorder. Prognosis doesn't seem to be great. This is a second presentation. This is a baby at 32 weeks having a right kidney normal, left kidney hydronephrosis and dilated ureter. She came at 34 weeks, 2 weeks later. Now both kidneys were dilated, both ureters were dilated, and there was a keyhole sign that was seen. 2 weeks earlier, we thought it was a unilateral problem, normal bladder. 2 weeks later, we have seen a picture of a lower urinary obstruction. So the problem can evolve over a period of time. But what is most scary is something like this. 20 week scan, everything completely normal, normal bladder, normal. Patient comes back at the third trimester scan, and by 31 to 32 weeks, you can see a distended bladder, bilateral hydronephrosis, and a dilated ureter. And by 33 weeks, the bladder has ruptured, the kidney has ruptured, there is urinary ascites on the perineum. So what started as a completely normal case at 20 weeks progressively worsened, and by the time we reach 33 weeks, we have ended up having a baby having a moribund outcome. The fourth presentation is a baby having a normal looking bladder in the initial scan, and by 21 weeks you have a very dilated distended geographic bladder, a bladder which has lost its function, and by around 29-30 weeks then you can see a distension of the bladder. But all this through period, like a consistently normal, kidneys dilated but parenchyma being normal, and these are the babies which may have a slightly better outcomes in the pregnancy because the presentation is in the third trimester and the renal parenchyma is not impacted till that point of time. Again, a very unusual presentation. Normal scan at the 20th week. The primary presentation was one of ascites. This patient was referred for a second opinion for ascites in the baby. Both kidneys were normal. We never had a hydronephrosis. We only had an ascites, and we couldn't make any diagnosis at this point of time. We said an ascites of unknown cause. Patient was called back in 2 weeks, and in 2 weeks, now we see a distended kidney, dilated bladder. So the way the problem progresses can be completely different. Isolated ascites and a diagnosis of a lower urinary obstruction. You can actually see the rent in the bladder when we did the 3D examination. So when we have a baby having a bladder obstruction, our concerns are, is a liquor normal or not? Because the liquor is normal, kidneys are functioning. Then is the parenchyma normal or not? Are there cortical cysts? And how is the bladder looking? Is the bladder too much over distended, or the bladder walls are too much thick? A thickened bladder, cysts in the kidney, echogenic kidney, reduced lighter, all these are signs of a compromised kidney function. And that's how ultrasound prognosticates whenever we see a baby with a lower urinary obstruction. And once we have this problem, there are methodologies by which we can offer prenatal therapy. First step we do in this regard is we do a urine sampling. This is a urinary bladder. We do 2 or 3 samples 2 days apart, and we assess the electrolytes on the beta-2 microgram. If it's more than 6, then they usually have unfavorable prognosis. If it's less than 6, then renal function is still maintained. And once we assess this problem, then we decide whom to intervene. And doing an intervention or deciding is very, very challenging. The problem must be severe enough not to compromise lung development and not severe enough to cause irreversible renal damage. So there's a very fine line you draw, because we don't go and intervene in everyone, and we don't intervene when the problem is very severe. And the 2 interventions are a vesicoamniotic shunting or a posterior urethral valve perforation. This is a vesicoamniotic shunt. This you're having this double shunt that is there, and this shunt is loaded on to the needle, and using an ultrasound guide, the shunt is punched inside the urinary bladder, and it is then pushed inside, and the shunt is deployed so that one loop is inside the bladder, the other loop is in amniotic fluid. And this can have complications. You can have shunt migration, and if there is renal damage already there, it doesn't prevent it. And the Pluto trial, which was published in 2013, changed the thought process. We were doing a lot of shunts prior to that, but what was shown, the shunt improves survival, but it doesn't prevent long-term bleeding. This is a baby that shunt has been done. Baby is born with this shunt. And this was again a baby where the shunt got displaced in utero, and postnatally was pulled out after birth. At 5 years, this baby is already having renal damage. So this is a challenge that need to be explained. The other therapy recently is being done is fetal cystoscopic fulguration, still under the gambit of experimental treatment, as I would say. This was a cystoscopic fulguration of posterior urethral valve. It was done under human. This is done using the regular 1 mm fetoscope that we use for multiple pregnancies, and a 600 nanometer laser fiber is threaded. And once we go in, we punch a hole inside at the level of the posterior urethra to give an exit for the urine pathway. So again, publications are very less. Very recent publications say that very strict criteria to determine whom we should offer this procedure, and they improve the 6-month survival rate, and the studies show that it may prevent the impairment of the function. But again, evidence is very less for us to cover. So prenatal therapy is offered in those cases before where the problem develops significant prior to viability. Strict criteria, and only in centers of excellence with proper counseling. The cystoscopic fulguration is also done for erythrocyte. This is a baby having bilateral erythrocyte, progressive hydronephrosis was happening. We did a cystoscopic fulguration of the erythrocyte bilaterally between the period. This particular case, the outcomes were very great. So we'll stop this discussion by publishing, by showing one of our data. This we for long we thought that renal malformations can only be picked up in the 2nd and 3rd trimester and beyond. So this was close to a 12-year data from our unit on renal pathologies that we were able to identify at the 1st trimester of pregnancy, where between 11 to 14 weeks. These were the common problems we picked up. 247 pregnancy renal problems. 120, 50% of them were those with a megacystis. 9% unilateral empty lymphosa, 10% bilateral empty lymphosa, and cystic echogenic kidneys contributed to 10 to 15%. And around 40% of them were isolated malformations, 60% associated. Very important point that thorough assessment of the rest of the baby. So what happened to them? When we saw a large bladder, very busy slide, I will go to the end point, close to 128 members, and in them, among the babies which had associated malformations, there were a large number, and among the isolated problems, when the bladder size was less than 15, over 50% to 60% of it, it regressed and the postnatal KUV was. The bladder size was more than 15, these babies didn't do well. But more important point, what we learned was these babies which had a large bladder due to a lower urinary obstruction. Large number of those babies had urethral atresia, and not only urethral atresia, they had associated problem. In the so-called isolated megacystis scan, we found babies having imperforate anus, high anorectal anomaly in 60%, and genital tract abnormalities in 35%. Absent external genitalia, ambiguous genitalia. None of this can be picked up on scan, wherein our challenge when we find these diagnoses, even in the midterm. Many babies associated with cardiac. Unilateral renal problem contributed to one group of the pregnancies. Majority of them, which were unilateral, babies were doing well. When there were associated problems, they were usually terminated. Bilateral MTV fossa, all of them underwent termination. Autopsy showed bilateral renal agencies, cystic kidney, or rudimentary or hyperplastic. And some of them have cyanomelia, and some of them they are part of an omphalocele extrophic complex, which involved vertebral malformations. Other problems involving renal were the hydronephrosis, which was seen as early as the first trimester, close to 40 cases, isolated 30%, and among those 30% of the cases which were isolated, we had 30% which were live born. Among the live born, one baby had progressed to a unilateral cystic dysplastic kidney. One baby, it progressed to UTD A2A3, and one baby, one group, it regressed. Then when we come to the cystic renal dysplasia, 80% of them was part of Meckel-Gruber syndrome. So key thing, rule out Meckel-Gruber syndrome. Remaining 90% of them, they were associated with other multi-system problems. It could be due to non-immune eye drops, it could be due to skeletal problem or finished nephrotic syndrome. So essentially, we had a large amount of data, and among this data, close to 140 of those cases which underwent termination. We had an autopsy study also, which added to our strength in identifying the problem. And what we found that the ability of ultrasound to pick up was quite good in good hands, was close to 90%. And multi-system anomaly and chromosomal abnormalities were there in quite a few. So counseling is essential. And the ultrasound sensitivity to pick up the problem in the first trimester around 70%. This was by far the largest correlation study to CAKUT anomalies in the first trimester. And this study also gave us a lot of light into the fact that the threshold for patients to terminate pregnancy is very high, even if we identified a unilateral problem. So to conclude, CAKUT is a spectrum, standardized terminologies to be used, can evolve over time, look for associated problems, look for liker, intervention in specific cases, careful counseling is essential. Thank you so much.
Thank you, Dr. Sudarshan, for a very comprehensive overview of the fetal imaging of CAKUT. Dr. Kalavani will take the questions at the end of the second presentation, or we have time to carry on with this?
No, sir, we will take up the questions towards the end of session, sir.
Okay. Then. Thank you, Dr.
Sudarshan. Sudarshan, sir, you will be staying back, right? So you're muted, sir.
I'll be staying back. I'll be staying back.
Okay, fine, sir. Thank you, sir. Saroj, sir, can you introduce Anita Patel, ma'am?
Yeah. So the second speaker for the day is Dr. Anita Patel. Dr. Patel is MCS, DNB, and FRCS in urology, a consultant urologist at Mumbai. She trained at KEM Hospital and did a MCH and DNB urology in 1991, and subsequently underwent specialist urology registrar training in UK in 1997. And she was assistant professor at KM Hospital for 2 years from 2017 to 19, and presently is a consultant at Endoscopic Clinic as well as Global Hospital Mumbai. And she also has been visiting faculty member at Wadia Children's Hospital Mumbai, and also had been a visiting consultant at Nadia Gujarat over the past 15 years. She has a specific interest in endourology and lower urinary tract dysfunction, both diagnosis as well as treatment across the entire age spectrum. And she has been a panelist for urinary incontinence guidelines by Urology Society of India and Urogenic Bladder by the Society International de Urology. She is an examiner for FRCS Urology in Singapore, and also has functioned as the chairman Public Education Committee of Female and Functional Urology subsection of Urology Society of India. So I would welcome Dr. Anita Patel and request her to give a presentation on uroflowmetry and urodynamic studies in children.
Thank you so much, Dr. Saroj. And at the outset, I wish to thank the organizers and in particular, Dr. Kalaivani, for asking me to be a part of this educational activity. Am I audible before I start sharing my screen?
Yes, ma'am.
Lovely, lovely. So I'll start sharing my screen. Okay. So my computer is asking me all sorts of questions. Dr. Kalaivani, you want to share what I had sent to you? Let me just make one more attempt. This is a new version of Zoom, which is not allowing me to do what I'm normally used to doing. Do you want to share your screen, Dr. Kalaivani?
Sure, ma'am, I can do that.
Yeah, I'm glad that I sent you the presentation.
Yeah.
You're muted. Yeah, sorry. Lovely. Yeah. So the only thing is that in this, do you change the slides? Because I won't be able to change the slides.
Yeah, I'll do it, ma'am.
Yeah, lovely. So I'll just keep on saying next slide.
Yeah.
Okay. So apologies for this. This is just a new MacBook, which is not listening to me and made me install the new Zoom. And that is how I logged in a little late. So apologies for that also. I must compliment Dr. Sudarshan for a wonderful talk. And it took me back to my MCH DNB days where we used to keenly follow all the tiny babies with their sonographies. So that was very educational. Thank you so much. Next slide, please. So I presume at least half of you or maybe more are comfortable with the concept of urodynamics. But before we switch over to the details of that, let's just look at normal bladder function. All of us have a normal bladder, and I hope so. So what is the normal urinary bladder supposed to do? It's supposed to store and empty. But it's not as simple as that. It's supposed to store at low pressure with no leak on posture change or vigorous physical activity. But we all are aware of progressive bladder fullness. As regards emptying, we must empty completely. Again, that too at low pressure without any straining in a steady, uninterrupted flow. And we are able to empty the bladder, whether it is 10 ml, 200 ml, 500 ml, depending on our age. So this is the best organ, I think, in our body. It listens to us. It has the both automatic and voluntary functions. Next slide, please. So, which is why I feel, can you switch to the next slide? Yeah. So if I were to say there is a happy bladder and there is a sad bladder family, the head of the family is at the bottom. So when the bladder behaves, the family is happy. When the bladder misbehaves, it's a sad family. So it's my attempt to show hydronephrosis, hydroureter, and generally a nasty situation. Switch the slide, please. So again, at least in urology, many people struggle to understand the physiology, and there isn't a great deal that we need to understand. S is for sympathetics, S is for storage. P is for parasympathetic, and P is for peeing. If we understood that, most of the physiology becomes very easy. The only voluntary control is the external striated sphincter. That's the somatic motor component. The reflex center is at the spinal cord, and the pontine micturition center has control over that. The Onuf's nucleus is located in the spinal center, of course. And the higher center control comes from the frontal lobe, which is what differentiates us from the animals. So we have a social component to our urination. And that is, we don't just, right now in the meeting, none of us are dripping urine. None of us are suddenly passing urine when we know that we are busy in a social activity and we are wearing full clothes and we are not in a washroom. So there are multiple layers which really are a part and parcel of normal urinary control. Next slide, please. So what happens in micturition? The first event is external sphincter relaxes. That's the only voluntary event. But let's understand, unless the external sphincter relaxes, the next event doesn't happen, which is the detrusor contraction. Even after detrusor contraction has started, the urination will not start unless bladder neck opens. So it must happen in this sequence. It's like an electrical circuit. And any break in this, there can be a problem. So once the bladder neck opens, we cannot stop voiding. That means, imagine many of us are desperate to pass urine, will rush to the washroom. We will not start dripping till we have sat on the commode or whichever posture that we want to pass urine in. We will still not start till the external sphincter opens. Then the detrusor contraction and then the opening of bladder neck. That sequence must happen. On an average, we pass urine about 5 to 6 times in a day. Each time we take less than, not even a minute, less than 20 seconds. So do the maths. In a day, we are not actually spending even 5 minutes passing urine. That means 23 hours and more than 50 minutes, we are busy storing urine. So when we are looking at urodynamics, when we are looking at damaged upper tracts, when we are looking at lower tract as the cause of damaged upper tract, it is not so much the voiding pressure, but it's the storing pressure, which is more important. So when I get patients sent for a urodynamic and I'm asked, I want to know the voiding pressure, I just want to tell them that, look, guys, it is not the voiding pressure, it is the storage pressure. A bladder which stores at low pressure is unlikely to be hostile. A bladder which doesn't store at low pressure, that's a hostile bladder. And that is important from nephrological point of view because it's very important from future transplant point of view. Next slide. So pediatric urodynamics is demanding, difficult, depressing. Any urodynamics, we must ask, why am I doing it? What question am I wanting the answer for? And how can I do the test in order to provide the answer? So this is not a test where a technician does it and you nicely sit in your cabin and interpret it looking at the graph, because it's a dynamic test. It's not a static test. So the person doing the test must be present for interpreting and doing it. The first test is the best effort because children are not going to be very cooperative. And we must be patient with our patients and follow all the kiddie things if we want the child to be cooperative. A detailed history, and we all are good at that. Storage symptoms, voiding symptoms, presence or absence of incontinence, hesitancy, any enuresis, any constipation. All of these should ring an alarm bell. A good clinical exam, if you're looking at lower urinary tract, must include not just examination of the abdomen, looking for palpable bladder, but look at relevant neurological evaluation and always do a rectal exam. And do all of these prior to doing any further invasive testing. Any child with a storage symptom merits a voiding diary or a frequency volume chart. And remember, children who have renal insufficiency may have a very large output as the only cause of their storage symptoms. So just because somebody is going frequently doesn't mean he or she has a bladder issue. You need to go into the details and rule out polyuria also. Next slide, please. So pediatric urodynamics, apart from the practical difficulties, we must understand that there is a risk of infection, more so in a child because children requiring invasive UDS have a compromised urinary tract. A video may be required. Now, a relevant point because video means fluoroscopy. Fluoroscopy means a lot of radiation, and lot of radiation of urogenital area means a future possibility of damaging the genitalia, testis and ovaries both, because you can't image urinary bladder and shield the ovaries or testis. So please keep that in mind. And repeated testing is not possible. So do your best shot. Miniature catheters may be required, usually 5 French catheter per urethral. The standard tests are flowmetry. Next is the cystometry, both voiding and filling cystometry, with or without EMG, with or without video. Of course, the aim is to differentiate between dangerous and safe lower urinary tract. Next slide, please. So what would be the indications? Who is it who requires a urodynamic? The first answer should be loud and clear, meningomyelocele. We need a baseline urodynamics. Now, what age should we do that? And now we know that we must do it literally within the first 6 months because the bladder goes through a lot of changes. And if we identify a hostile bladder very early, especially for children with high meningomyelocele, we may be able to start them straight away on antimuscarinics as well as a program of intermittent cath, which will be taught to the parents. What about the PU valves? So usually after the valves are fulgurated, the child is monitored by sonography. And once the child learns to void on command, just a flowmetry is all that is required in every patient. But the invasive testing, which means cystometry, is required only if the child has voiding dysfunction, which is disproportionate to his overall health progress, which may or may not include leakage, both during the day and night. The child who has unexpected rising creatinine, or a child who has persistent or rising VUR, which otherwise just a fulguration done properly is not able to explain. That means we should study the bladder better. Those with spinal tumors, not a very common condition, but all of them merit urodynamics, especially prior to surgery. Those with reflux, and we'll look into that a little details. If they have persistent or recurrent reflux or reflux with voiding dysfunction merit a UDS. Extrophy, if despite a satisfactory repair, there is persistent leak, they merit a UDS. And any child who is otherwise normal, that means none of the other conditions, but has age inappropriate nocturnal as well as diurnal wetting, merits UDS. And last but not the least, dysfunctional voiders or those who have dysfunctional elimination syndrome. Thanks, Dr. Kalaivani. The technique is very simple, but some important points. Very small catheter, usually 5 French 2 catheters. In theory, suprapubic catheters so that you leave the urethra free. A lot of these things remain in theory. You don't have a suprapubic facility in a child as a routine. So urethral catheter. Fill speed, 10% of a known bladder capacity. We all are familiar with the standard formulae, but a child who is more than a year old, and except for meningomyelocele, most children coming for UDS will be more than a year of age. Standard Cox formula is given here, and all of you are familiar. Age in years plus 2 multiplied by 30 will give you the bladder capacity for that age, and you make a 10% of that as the fill speed. So if a child's capacity is say 150 mLs, then you will fill the bladder during urodynamics at a fill speed of 15 mLs per minute. We use a voiding diary to know the functional bladder capacity. Now, functional bladder capacity is the most frequently voided urine on a bladder diary. For example, for an adult, for all of us, we usually pass about 250 to 300 ml per urination. For a child, use a voiding diary, and if you don't have that, then use various formulae. Use nomograms if you are in doubt. As I said, antibiotics and video very often required. Click on this slide, please. Go on clicking. So capacity, compliance, continence, coarse bladder sensation, which is proprioception, and detrusor contraction, which may be underactivity or overactivity. So multiple C's are required. Sorry, this presentation didn't have that, and the one on my computer has it. But basically, C for capacity, C for compliance, C for continence, C for coarse sensation or proprioception, C for contraction. If you remembered all of these are the parameters we study. If we are reading a video, use the same technique that you use for reading any MCU. That means, what's the size, what's the shape, is the bladder rising out of pelvis? If there is a reflux, then at what volume the reflux starts? Does the bladder contour change or enlarge with progressive filling? Or in those with VUR, is everything going up in the kidney? That means that bladder is not developed only. And is it a filling reflux, which usually indicates a poorly functioning VU junction? Or is it just a voiding reflux? Now, a voiding reflux alone would mean high pressure voiding. Is the outlet closed or open during any overactivity? That means, is it overactivity wet or is it overactivity dry? As a rule, children who wet may be safer than those who don't wet, because that may mean a high pressure bladder. Flowmetry alone is used predominantly in 2 conditions. Those with valves, and by that I mean most commonly PU valves, or those who have undergone some kind of hypo or epispedia surgery, whereby there could be post-surgery a structural narrowing in the urethra. There are nomograms available, but look at the graph on the right half of the screen. The graph on the top shows a classic bell-shaped curve. So flowmetry must have a bell-shaped curve. The maximum flow should be age-appropriate, and there are nomograms available for that. The graph must show a bell, which means it goes up, comes down as a bell-shaped curve. Now let's look at the graph at the bottom. There is a rapid upstroke, and then there is a box-shaped pattern. And this graph doesn't have a bell shape. This is a classic flowmetry in a mechanical blockade in the urethra, usually some kind of stricture following hypospadias repair. Next slide. So this is a normal bell, upstroke, downstroke, nice smooth curve. Tap on the screen again. This is a small voided volume, but again, a bell, not bad. We see that in children with overactive bladder. Look at the voided volume on top, less than 100. Tap again on the screen. That we looked at already. That's a box-shaped curve in a classic mechanically obstructed urethra. Tap again. This is a very fast curve. Children who have overactive bladder, usually, grown-up kids, 5 or 6 year old. Again, the voided volume is not very high. Look in the top half of the bottom graph, and you will see the voided volume is hovering around 200, but it's so rapidly going up and down. And these children run to the washroom, finish the job, and come back running. Before you realize they've gone to the loo, they're out. This is classic overactive bladder seen in dysfunctional voider. And the next one, please. This, though it is seen more commonly in adult children who have a bad outlet, may leak on coughing. So at the beginning, you see a little bump, then the rest of the curve. So these are the standard flowmetry variations that you will see in pediatric practice. Next slide. This is a typical invasive urodynamics. This is a filling and voiding cystometry. And if you look at the graph carefully, the top line tells you the flow pattern. The second one from the top tells you the voided volume in milliliters. The third one, which is usually a green, it's a universally accepted color scheme. So the green is the detrusor pressure, the one below blue for bladder. So that's a combined bladder and rectal pressure. And the one at the bottom is usually either red or black, and that is the abdominal pressure. During a urodynamics, a tube is put in the urethra, a tube is put in the rectum. Both are connected to a computer. A separate filling line is kept for filling the bladder at a fixed speed. During the test, the child is asked to cough repeatedly. So on the blue and black line in the left half of the screen, you will see repeated coughs. Each of that cough tells that the pressure transmission is correct. The detrusor pressure is usually derived by the machine. It is not directly measured by the catheters. So the detrusor pressure is derived by subtracting abdominal pressure from the vesical pressure. And the detrusor pressure will be a flat line unless there is an event happening in the bladder, such as an overactive contraction or a poorly compliant bladder. So the graph on the next, this slide in the right half is showing, compare it with the graph in the left half. So if you look at the detrusor line, you are seeing little bumps every now and then. They are seeing only in vesicle and detrusor line. And if you look at the topmost line in the graph showing detrusor overactivity, commensurate with every detrusor contraction, you are seeing a leak episode. So this is a child where with every detrusor contraction, the child is wetting. We see this situation in dysfunctional voiders where they try their level best to contract. They may show Vincent's curtsy as a sign, but there are situations where they can't control and they'll end up wetting their clothes. And if the same thing happens on the UDM machine, this is what you will see. So compare the right half with the left half. Now, when we're talking about compliance, look at the left half of the screen, the normal UDS. The green line remains steady till such a moment when the person is given a command to void. So when we talk about compliance, and that is a very important yardstick to decide if the bladder filling pressures are safe, the normal bladder is not supposed to show any pressure rise while the bladder is getting filled up. So that's a normally compliant bladder. How do you know that the bladder is poorly compliant? That means for every 10 mLs that we fill at an appropriate age-appropriate fill speed, the pressure will start going up by 1 centimeter. So if 100 mLs is filled and the pressure is 10 centimeter, that would be a normal compliance. But if 100 mLs is filled and the pressure is 20 or 30 centimeter, that's a poorly compliant bladder. Not only that, if you read the original Maguire, monogram on urodynamics, if the filling pressure rises above 40 centimeters, normally filling pressure should stay below 10 centimeter, irrespective of how much you filled. If the filling pressure rises above 40 centimeter, the urinary tract leaks. Where does it leak? It leaks upwards or it can leak outwards. The urinary tract which leaks upwards is more dangerous because it can manifest in the form of dilated upper tracts or reflux. Urinary tract which leaks outwards may be safer because these children are having externally manifest leak, but their kidneys are safe. So that's a very simple rule to remember. Next slide, please. So I'm showing a video. It's a handheld camera. If you see how the detrusor contraction is appearing, and it is slowly going down, and with that, there is a leak on the top line. So this is a person who had repeated overactive contractions, but with the second contraction, the child leaked. This is how you would see that if you were present during a live urodynamics. As against that, the graph in the left half shows repeated overactivity. There is no leak, but the pressure goes on rising. The P det line, the green line, just goes on steadily rising. And if, I don't know if your screen, you're able to show the bottom table, what I've filled is barely 9 mLs. This is a child who had a defunctionalized bladder with a vesicostomy because the child had presented in a bad state with urinary ascites, and this decompression was done as a life-saving procedure. This is a bad bladder. And if one were to hope that this bladder will improve, either bladder cycling or eventually maybe some form of augmentation. So it is the filling pressure, remember, again and again I will go on mentioning, which decides a dangerous bladder with a potential to damage the upper tract. Next slide, please. Next slide, please. Go back. So we all know valves. Well, there's a wide spectrum of bladder dysfunction, not necessarily associated as a cause and effect manner with valves, which is why such children need lifelong monitoring, because even after valves are fulgurated, you will see a degree of bladder dysfunction because their bladders are genetically programmed to behave in a certain manner. Unmonitored, the children can progress to end-stage renal disease or CKD. So the bladder can shift from being overactive in childhood to a spectrum of myogenic failure, that means poor contraction, but poor compliance as a result of deposition of collagen, to eventually a completely floppy acontractile organ by teenage. And the only way to monitor that would be by doing urodynamics at fixed intervals. When do we do the first UDM? I'll talk about it very soon. But a basic non-invasive study, which is flowmetry with post-void residue, is a must in every child once they're able to void on command. Invasive monitoring for the first time after the age of 2 years in selected cases. Next slide. So this is a child who presented with crying during micturition. Slow flow at the age of 5 months, creatinine 0.4, MCU was done, which is what would be the first test done. The MCU showed, of course, bilateral VUR, classic valves. The sonography was also done, which had confirmed bilateral dilated upper tracts. So he had valve fulguration at 6th month of life. Post fulguration, everything was fine. And this is the scene in India. The child said tata bye-bye. Parents said tata bye-bye, very happy. Next slide. About a year later, creatinine was 1.5. Go on tapping on the slide. So what would be our plan? A sonography, a renal scan, MCU, UDS? Well, all of the above in that order were done. But again, sonography showed massive hydronephrosis, hydroureter. So a ureterostomy was done before doing any further monitoring or imaging. This immediately led to drop in creatinine. Tap on the screen. And this is the same child. If you see now on the image, the child is obviously little grown up. There is bilateral VUR, but that is better than what was seen before. And there is a vague suggestion of persistent narrowing in the region of the posterior valve. At this stage, we came in the picture. Tap on the screen. So by then, the child was able to void on command, and we were lucky to catch that. So there is a small voided volume. The flowmetry is on top. There is an attempted bell-shaped curve. Tap on the screen. So on the bottom, there is invasive urodynamics done at appropriate fill speed. The child was very small, so we barely filled the bladder at about 8 mLs. There is obvious overactivity. There is leak with overactivity, but the pressure comes back to normal. The compliance is not bad. So this bladder is not bad. At this stage, oxybutynin was started. Renal scan was done. Right was the worst affected kidney. It showed 20% right renal function. So before closing the ureterostomy, very close monitoring was advised, and eventually this child normalized with a creatinine which was age appropriate. He stayed on oxybutynin, and also after closing ureterostomy, for a while, nighttime urethral catheter was maintained. So a very close monitoring was done. Next slide, please. Meningomyelocele is a set of children who basically have a dangerous urinary tract. And they, amongst all the pediatric voiding dysfunction situations, have the highest possibility of damage to the upper tracts. This is an 11-year-old boy, operated for lumbosacral meningomyelocele in infancy. Bladder bowel incontinence, but unfortunately, and I repeat, these children after their first surgery are left for nature and God to look after, because the importance of lifelong follow-up is very often not emphasized in the minds of the parents. And this is nothing related to socioeconomic strata. I see very committed parents looking after meningomyelocele children, and they are impeccably preserved, even though they may be staying in a jhopda, for example, because the caregiving physician and surgeon have drilled in their head the importance of lifelong follow-up. So this is an 11-year-old boy, bladder bowel leak, though he voids on command, but he's wet day and night. He was initially on CIC, he gave it up during lockdown, one of the many sort of health casualties of lockdown. Motion is every day after an enema. Examination showed all telltale signs of renal dysfunction. So wasted calf, short stature, varus deformity, smelly clothes, poor bulbocavernosus reflux. Tap on the slide, please. So what do you want to do for this child? Tap on the slide. So this is what we did. Go back. So you want to, if I am to ask the PGs, what would you do? You will still go by the standard sequence: simple test, non-invasive test, and invasive test. So urine analysis, look for all the parameters. Nephrologists don't need to be told about various parameters on urine analysis. CBC, because he's pale and is already CKD has set in. Sonography to know bilateral upper tracts, and renal chemistry. So creatinine is 1.8, hemoglobin is 8, bilateral mildly dilated upper tract, increased renal echo, thick walled small capacity bladder with a random volume of 100 ml. Let's go ahead. Next slide. So he was referred for a UDS. The UDS showed continuous low pressure overactivity. He leaked every time. So he leaked outwards. Thank goodness for that. He wasn't leaking upwards, but the bladder is hostile. This bladder is not really suitable and it needs active treatment. So how would you follow up this child, both clinically and urodynamically? So the continuous overactivity means he needs to be on antimuscarinic. Despite the overactivity, he doesn't empty well because the outlet doesn't open freely. It just allows leakage. That means perhaps self-cath may be required. Next slide, please. So meningomyelocele children are very dangerous from continence, infection, and CKD point of view, and they need very aggressive management. Next slide, please. So we were talking about vesico-ureteric reflux and voiding dysfunction. The figures are there in every book, but important thing is that high pressure voiders may develop renal scar despite absence of infection, and high voiding pressure may be due to a detrusal dysfunction, which could be due to a transient in utero obstruction. We saw signs of that. We saw imaging very beautifully shown by the previous speaker. Next slide, please. So when would you do urodynamics in vesico-ureteric reflux? The indications are clearly given, but usually somebody who presents with voiding dysfunction with VUR, where on MCU the bladder has actually failed to develop, everything is going up, and you're either not able to control the reflux or control the infection, or despite properly done surgery, there is persistent or recurrent reflux and deteriorating upper tracts. It is always best to use a video. In the literature, there is a mention of using ureteric occlusion catheter because otherwise that pop-off leads to wrong reading of volume and pressure, but this is in theory. I have never done that. But also remember the risk of radiation exposure in these children. So you need intelligent interpretation of UDS. Tap on the screen again, please. So there are technical difficulties. There is a pressure pop-off because as the urine starts going up or the reflux starts, the bladder pressure just equalizes. So the rise in pressure happens very end when the upper tract and bladder are completely filled with urine. But by then, the actual pressure is way higher than what the machine records. There is a volume pop-off. That means during urodynamics, you will see a report showing we filled 240. But if you did a video, you will see a very tiny bladder and everything going up in the upper tracts. So there is a volume pop-off, and there is a very wrong assessment of post-void residue. Because if the child voided and emptied the bladder, 2 minutes later, whatever went up will come down in the bladder. And if you were to do a sonographic assessments, or you were to see on opening the catheter of UDM, you'll get a very wrong assessment of PVR. So it is difficult to do a UDM in VUR. Next slide, please. So is it necessary at all? Does it change the management? And are there any pointers in pre-urodynamic tests which will indicate a bad bladder? So the literature review fell short of this, and I presented my statistics several years ago in Kenya, and we came up with a conclusion that a bladder on MCU, which rises out of pelvis, the reflux which may be high grade but predominantly filling, the outlet is opacified normally and non-dilated in the voiding images, and the child clinically doesn't have voiding dysfunction, is least likely to be hostile. Anything else which doesn't fill into this is likely to be hostile. Next slide. So 2014, the child presented at the age of 4 years, no antenatal imaging, no LUTS so far, voiding on command, no daytime wetting, rarely enuresis, if not woken up to void, but recently had fever with urosepsis. Investigation showed rising creatinine. Sonography showed bilateral dilated upper tract. MCU only report was available, high-grade filling reflux, no residue. Tap on the screen. This was his flowmetry. That's the best flow that we had, 4-year-old child. Next slide, please. Tap on the screen again. So on the left half is the filling part of the urodynamics. If you see the green line, steady flat line, except slight terminal rise. You know why? Because everything was going up, high-grade reflux. No overactivity, no leakage episode because everything went up. If you now see in the right half of the screen, that's the voiding cystometry, there is some attempt at voiding, there is some detrusor contraction. The child voided completely. So that's a good sign. The child voided almost 400 ml plus. That means even though there was reflux, the emptying was not bad at all. Urodynamically, we describe this bladder as not hostile. The voiding was with abdominal straining, which is hostile in a child who has bilateral high-grade reflux. Tap again, next slide. Next slide. Okay, so this child again disappeared somewhere. This is the usual story. He was told to observe double urination, timed urination, etc. 2019, the same child present. So now add 5 years to that. So 4-year-old, so he's now almost 9 years of age. Creatinine is 5.3. Mom was told 3-hourly CIC. She followed that only for a few days. Now he voids daytime 2 to 3 hourly, wets if not woken up, short kid, raised creatinine, no fresh imaging. That's his flowmetry. Attempted bell-shaped curve. That's his pressure flow study. Tap again on the screen. So on a pressure flow, it showed a large volume. The curve was bell-shaped, the voiding curve, but no detrusor pressure during voiding. So again, this urinary bladder was declared as hostile because everything was probably going up. Tap again on the screen. Tap again. 2022. So this is, I do have longitudinal follow-up of several valves and reflux children who have a dangerous bladder. So now he is 11 years of age. Bilateral VUR, established CKD, he's on hemodialysis. Continues to have hardly any LUTS. He was lost to follow-up. He voids 3 times a day, reports a good flow. There is no enuresis. Creatinine is 4.9. Bilateral small hydronephrotic kidneys. Tap on the screen again. Finally, we have his MCU. All the other MCUs were lost. And this is a real-time case, which is why I have put it up. And if you see, there is bilateral filling as well as voiding reflux. It is a grade 4 reflux, left side a little more than right. But the good thing is that he's emptying to completion. And there doesn't seem to be any posterior urethral dilatation. Tap on the screen again. Next slide, next slide, next slide. So again, this bladder continues to have slightly reduced compliance, but that is in face of pop-off. The voiding is entirely with abdominal straining. Is this bladder safe? The urodynamic answer is no. Will he need a reimplant, transplant? This bladder will not be safe for reimplant. What if you left both the kidneys in situ and put a transplanted kidney? Should he have a nephrouretrectomy? This is where a combined urodynamic person, all of them should meet together and decide, because this bladder is hostile. So the job of a urodynamic test is to really handpick those who may be having hostile bladders. Next slide, please. This is the spot. All of you know that this is a classic exstrophy, wide pubic diastasis. Next slide. What do we see in such children? They typically have overactive contractions. If you see in the green line, there is overactivity. They often present with wetting, not just because of overactivity, but because their outlet is also wide open. Very difficult group, because very often they also have bilateral VUR. And urodynamics is challenging, but it must pick up the overactivity, which it has done. These children need long-term antimuscarinics. You all know there are issues with that. They need bladder neck tightening and some kind of reconstruction. And unfortunately, in a small minority, this is one situation where pediatric augmentation may be required. Not an easy decision surgically. Next slide. Forget all that. That is a clinical detail. We will be coming to the end of this. Next slide. So, in a nutshell, clinical parameters should supersede any UDS. You know, I often get a request, child with valves, UDS. I mean, what are you wanting to know? Do you want to know whether his flow is normal? You want to know whether he has overactivity? Do you want to know he has poor compliance? So what is the urodynamic question? Once the child is considered ready for urodynamics, please don't proceed without a urine report. I will send the child back, because these are compromised urinary tract, and presence of active UTI and urodynamics is a complete no-no. Insist on imaging, especially non-invasive, because sonography with bilateral dilated upper tract, I'm wanting to know why. Is it UV junction obstruction? Is it reflux? So when necessary, I will do an MCU, and I'll do all of these before a UDM, because a video UDS facility may not be available everywhere. We must use a bladder diary when required. We must use a CIC diary when the child is being catheterized. And a wild child can be followed up on just plain flowmetry PVR, but meningomyelocele are the most dangerous urinary tract. They will progress to CKD if not managed properly. So they must have their baseline UDS literally within the first 6 months, and thereafter at 2 years, 5 years, and subsequently as and when deemed necessary based on their clinical parameters and imaging. In vesico-ureteric reflux, the role of urodynamic remains controversial, but any child who has a reflux that you can't explain or reflux with voiding dysfunction, please have a very low threshold for doing a urodynamic study. Thank you so much. I hope I've been able to throw some light, and my apologies for not being able to share my screen, because I could have clicked a little faster. Dr. Kalaivani, thank you so much for your cooperation. Thank you.
Thank you so much.
I hope I have stuck to the time. Thank you.
Yes.
Thank you, Dr. Patel, for such a lucid and comprehensive presentation on UDS in children. There are a couple of questions from the trainees.
So do you want me to answer? Because I've
Yes.
seen them all.
Yes, ma'am.
So what's the normal bladder capacity for child more than 12 years? It's like an adult. So you don't apply any formulae for a normally developed child. So a capacity can be anywhere from 300 to 500 mLs. You don't need a formula for that. Do we need to do a MAC3 after fulguration of PU valve? And what is the purpose of it? So why would you do MAC3 after a PU valve? MAC3 is for renal functional assessment, and we as urologists would use it if there is a question of obstructive drainage, especially if there is a PU junction anomaly suspected. But PU valves, the functional study will be done only if renal function is in doubt, and that would be usually DMSA. I want to study for scars if there are any, and any MAC3 or what we used to do previously, EC scan with a diuretic, I would do if I'm suspecting bilateral UV junction obstruction. How early should we do UDS in meningomyelocele patient? I think I answered that in my talk. Within the first 6 months, please. Kindly repeat the criteria you said for a hostile bladder. So my apologies because I had included that in my new presentation, but I will repeat. If on MCU, you see a bladder which is not rising out of pelvis, if a bladder has crenated silhouette with evidence of saccules and cellules or something like a Christmas tree bladder, if you see a bladder which shows filling reflux, and if you see a bladder where the outlet is open when the child is not supposed to void, that's the hostile bladder. And the voiding part of MCU, if there is dilated posterior urethra, irrespective of whether there are valves or no, this is a hostile bladder. All the other bladders, that means smooth silhouette, good capacity, maybe low-grade filling reflux, and a complete emptying with an open outlet, non-dilated posterior urethra, and emptying of upper tracts and bladder, such children are least likely to have a hostile bladder. I hope I made that clear.
Thank you, ma'am. I have one question, which is
Yes,
what are the challenges of UDS in the neonatal period? Do you do it in a neonatal period?
I don't. I have very rarely done it in a neonate. There are multiple challenges. The biggest challenge is you're occluding a neonate's urethra with any catheter that you use. Okay. Now, the smallest double lumen catheter we get, I think, is a 5 French. A double lumen catheter means during voiding, you're not able to remove the catheter. But let's see, in a neonate, you're not looking at the voiding phase. You're simply looking at a bladder which is storing at high pressure. So a 5 French double lumen would be fine. The challenge is that there are no nomograms to tell us what is normal neonatal bladder function, because there isn't a control group. So for us to diagnose overactivity, which will be seen in practically every neonate who is normal, will be very difficult. But what I can diagnose is a steadily rising filling pressure. That means poor compliance. So that would be the only information, but still, why in a neonate? If I have any doubts, I will preemptively put the child on appropriate management and perhaps do any test involving catheterization, sorry, no sooner than 6 months. That would be my reply. Thank you so much.
Thank you very much for clarifying that point. And so practically, what would be the youngest age you would take on a case for?
So
UDS?
I have done 6 months as the youngest, okay, and that was for a meningomyelocele. But otherwise, everything else is usually 2 years and above. We know dysfunctional voiding doesn't happen before that. Anorectal malformation is a nasty group, but by the time they come to a UDS, they are 2 years and plus, because there are too many bowel issues before that. Valve children very rarely need invasive urodynamics above the age of, below the age of 2 years. So 2 years would be like a watershed.
And for uroflowmetry alone?
Uroflowmetry alone, any child who voids on command. And there are children who do void on command at a very young age. Though they are not truly volitional voiding, they are reflex trained. You know, in India, we take great pride. I trained my child to void on command at 6 months. No. You did when the child learned how to void. But that doesn't mean the child's bladder is behaving at his own will. So any child who voids at will, usually 1.5 years, flowmetry can be done.
Thank you for the clarification.
Thank you. Thank you.
I have one question for Dr. Sudarshan. What is the, so you focused upon fetal sonography for detection of various CAKUT anomalies, but what is the role vis-a-vis a fetal MRI? In which situations would you add on a fetal MRI on top of urosonography? I've
never added fetal MRI for fetal renal system assessment. From my experience, a good transvaginal ultrasound and a high frequency probe, transabdominal ultrasound, gives us enough information for us to proceed forth.
Thank you very much for clarification. Now we are running short of time and overshot our time period. So Dr. Kalavani, can we move on to the polling session?
Like they can stay back, otherwise they can leave, sir, like because like we are already running short of time, and it was really an excellent session, and it was like a picture to picture teaching session. It was very much informative. We have learned a lot from the session. Thank you, Dr. Sudarshan. Thank you, Anita madam. It was really a crystal
you so
clear
much.
presentation. Thank you so much, ma'am.
Thank you.
If you would
Thank you.
like to
Bye-bye.
stay back for the polling session.
I don't mind. I'm just curious. So I'm just going to mute.
Okay. So we'll go on to the polling session. The instruction for the polling session are follows. All participants are requested to enter the proper email ID so that we can have a easy communication in future. And totally we have 10 polling sessions, and it is starting from today, and we have it every Wednesday and Saturday. And it is mandatory to answer all the questions to proceed with the submission. And total duration for this polling session is going to be 10 minutes. And we will have 3 star questions in each session. And the star questions are taken into consideration only in case of tie. And the cumulative score of all 10 polling session will be taken as a final mark for the selecting the winners. And the prize rewards are 15K, 10K and 7.5K. And only trainees are allowed to participate in the polling session. And I request all the participants to log in on time using a bigger screen for ease of viewing the questions. And for better view in iPad tabs, use landscape mode. And once you log in, you can use the same webinar link to enter into the polling session. So the polling session is for 10 minutes, and we'll start the polling session right now. We still have 5 more minutes for the polling session. We still have 1 more minute to go. So we are in the end of the polling session. We are closing the session.
Thank you, Dr. Kalaivani.
Thank you so much, sir. Thanks for the excellent moderation. Thank you so much, sir.
Yeah. Thank you, Dr. Patnaik. Thank you, Dr.
Thank you,
Patnaik.
Dr.
Thank you, Dr. Sudarshan.
Thank you very much.
We really
Thank
appreciate
you, Anita ma'am. Thank you, Sudarshan. Bye, Amrish. Thank you so much.
Thank you.
Thank you.